Hello, and welcome to Grand Rounds for the Minnesota Regional Spinal Cord Injury Model System, or MINSCIMS for short. Thank you all for joining us today. MINSCIMS is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research to support innovative projects and research in the delivery, demonstration, and evaluation of medical, rehabilitation, vocational, and other services to meet the needs of individuals with spinal cord injury. Next slide. MINSCIMS represents an exciting new partnership among the following institutions: Courage Kenny Rehabilitation Institute, Minneapolis, Minnesota; Mayo Clinic, Rochester, Minnesota; Regions Hospital, St. Paul, Minnesota; and the University of Minnesota, Minneapolis, Minnesota. Next slide. Our community collaborators include Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, Get Up, Stand Up to Cure Paralysis, Paralyzed Veterans of America, United Spinal Association, and the North American Spinal Cord Injury Consortium. This system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including emergency medical services, acute care services, acute rehabilitation services, and post-acute services. My name is Dr. Leslie Morris, and I will be the moderator of today's session. I'm a professor and the head of Department of Rehabilitation Medicine at the University of Minnesota Medical School. I'm the co-principal investigator of the MINSCIMS with Dr. Kimberley Monden and the co-chair of the Model Systems Knowledge Translation Committee. Next slide. A few housekeeping notes. The University of Minnesota has organized the CME for today's webinar. Please see the chat for information on how to record your attendance and claim CME credit for attending this webinar within 24 hours of the event. This meeting is being recorded and will be posted on the MINSCIMS website. To earn CME credit for today's presentation, please click on the link in the chat. Due to the number of registrants for today's webinar, we have placed phone lines on mute to reduce, please place phone lines on mute to reduce audio feedback. However, we welcome and encourage audience participation using the chat and Q&A functions. If you have technical or logistical questions, we ask that you submit those in the chat to Dan Kelly, who will be monitoring the discussion. Next slide. The title of today's presentation is COVID-19 in the SCI Community, an Observational Longitudinal Study. The speaker for today's webinar is Dr. Kimberley Monden. Dr. Monden is an associate professor and licensed psychologist in the Department of Rehabilitation Medicine at the University of Minnesota Medical School and has 12 years of experience in SCI clinical care and research. Dr. Monden studies resilience and appraisals of injustice with a specific interest in improving quality of life and long-term psychosocial outcomes after spinal cord injury. Dr. Monden has research funding from NIDLR, the Department of Defense, the Paralyzed Veterans of America, and the Craig H. Nielsen Foundation. Dr. Monden serves as co-project director of the Minnesota Regional SCIMS. Dr. Monden, welcome and thank you for presenting today. Next slide.
Thank you, Leslie. Thank you for the lovely introduction. And I have no conflicts of interest to disclose today. And the study that I'll be talking about was an unfunded study. So as Leslie mentioned, the title of my presentation today is COVID-19 and the Spinal Cord Injury Community, an Observational Longitudinal Study. So today I'll be talking about a body of work around the impact of the COVID-19 pandemic on the SCI community. Specifically, I'll be discussing various findings from our longitudinal observational study that was conducted during the first year of the pandemic. I'll be covering several topics today, so this gives an overview of what we'll be discussing. I'll start off talking a little bit about medical discrimination and rationing that was occurring early on in the pandemic. Then I'll provide an overview of the study and our data collection methods. I'll talk about supply chain issues, access to medical supplies, and access to personal care assistance. I'll talk a little bit about general health, social isolation, and mental health during the pandemic. And then I'm going to be talking about two different studies, hopefully two if I have time. The first one is resilience and mental health in individuals with spinal cord injury during the COVID-19 pandemic. And the second study, if we have time today, is changes in essential care among individuals with spinal cord injury during the COVID-19 pandemic. And then we'll have time for questions and discussion at the end of the presentation. So early in the pandemic, there was concern among SCI professionals and the SCI community about the impact of the pandemic on this population for several reasons. And as you can see in the circle here on the right-hand side of the slide, as we know, individuals with spinal cord injury are often immunocompromised, which puts them at increased risk for respiratory infection and at greater risk of health deterioration as a result of COVID-19 and the associated public health restrictions as well. And because of these factors, they may experience compounded stress related to the impacts of the pandemic. And so this is really what got us thinking early on in the pandemic that it would be helpful to get a study underway to see how the pandemic truly was impacting the spinal cord injury community. As many of you may recall, early in the pandemic, there were fears and legitimate concerns about disability-based discrimination. Early on, the American Bar Association highlighted problematic provisions of care, including categorical exclusions based on disability, failing to allow adequate time on ventilators due to disability status, and authorizing reallocation of ventilators from chronic ventilator users to other patients. Early in the pandemic, crisis care standards and triage protocols emerged that were expressly biased against disabled persons. Health and Human Services opened investigations and warned against possible violations of the Americans with Disabilities Act. And disability activists and medical ethicists advocated for crisis triage protocols that did not unfairly disadvantage disabled people. And they encouraged these triage protocols to focus on near-term prognoses and encouraged healthcare facilities to adopt a transparent process to reduce bias in decision-making. Now, I want to briefly discuss the case of Michael Hickson. For those who didn't hear about this case, or for those of you who did but need to jog your memory, Michael Hickson was a 46-year-old Black man who lived in Austin, Texas. He was a husband and father of 5. He was a Morehouse College graduate who was an auto insurance claims estimator. He was driving his wife to work 3 years ago, and when he went into sudden cardiac arrest, which resulted in an anoxic brain injury, blindness, and tetraplegia. Michael Hickson contracted COVID-19 in the spring of 2020 and was subsequently hospitalized. So I'm going to play some audio here. There really isn't any video of a conversation between Michael Hickson's family. Primarily, it's his wife speaking and the doctor at St. David's, which was the facility he was at in Austin, Texas. The audio isn't the best quality, but there is text at the bottom of the slide, and this is about 4 minutes long.
Kim, I don't think we're hearing any audio.
I'm not sure how to make the audio play if you're not hearing it. Do you think it has to do with the fact that I have my AirPods in?
I'm not sure, but maybe you could read it because we can see, maybe you just read it as it progresses, Kim.
Sure. Okay. This may start again. Sorry, technical difficulties. Okay. So this is the doctor speaking, and they're talking about starting him on a certain drug. And he's saying that right now the criteria is requiring intubation. So if you were to get intubated, then you would be, but at this point with the decision is, do we want to be extremely aggressive with his care, or do we feel like this will be futile? And the big question of futility is one we always question. And the issue is, will this help him improve his quality of life? Will this help him improve anything? Will it ultimately change the outcome? And the thought is, the answer is no to all of those. What would make you say no to all of those? Because as of right now, his quality of life, he doesn't have much of one. What do you mean? Because he's paralyzed with a brain injury, he doesn't have quality of life? Correct. Who gets to make that decision whether somebody's quality of life, if they have a disability, that their quality of life is good or not? So it's not me, I don't make that decision. However, it's, will it affect his quality? Will it improve his quality of life? And the answer is no. Why wouldn't it? Being able to live isn't improving the quality of life. There's no improvement with being intubated with a bunch of lines and tubes in your body and being on a ventilator for more than 2 weeks. Each of our people here have COVID and they're in respiratory failure. They've been here for more than 2 weeks. So they're basically on the ventilator till they'll die. If I were to be frank, yes. So if somebody doesn't die, are you going to, so I can count with one hand the 3 patients that have made it through. You can count 3? Correct. Exactly. I get your point. There are 3. However, he doesn't fit those 3. Those 3 are young people that don't have medical problems. This guy is young, but he has a number of medical problems. So just so you know, my uncle is 90 years old. He got COVID. And he has a bunch of medical problems. He has cancer. Well, I would consider that a blessing every minute he's still alive. Which is why, to me, you can't say that though, because all the directions pointed to him as being high risk that he wouldn't make it, and he did. Why would somebody pass away when he's younger than him? Well, I'm going to go with the data. I don't go with stories because stories don't help me. So they fought it on their own? Correct. With oxygen? Correct. So they were there about 1.5 to 2 weeks, or some of them even longer. So he's been here since Tuesday now. However, his quality of life is different from theirs. They were walking and talking people. He can't walk now. Right, and I don't mean to be frank or abrasive or anything, but at this point, we are going to have to do what we feel is best for him along with the state, and this is what we decided. So the fact that you're killing someone doesn't make sense in your mind. We don't think it's killing because I don't know when or if he'll die, but I do think, well, we're all going to die at some point. Exactly, you're right. We're all going to die. So I don't know when or if he'll die, but at this point, I don't think it would be humane or compassionate to put a breathing tube in this man and do the lines and tubes and all that stuff because I don't think it will benefit him. And I totally agree with you on the intubation part. I don't want him intubated, but also don't you think you should just sit him somewhere to be I also don't think you should sit him somewhere to be comfortable until he finally dies. That to me is futile too. That's saying you're not trying to save his life. You're just watching them go. The ship is sailing. That doesn't make any sense to me to not try. I don't get that part. It's not easy. None of these things are easy. And this is a calculated decision. And we feel like this is what is going to be best for him. So I will stop it there. And I apologize that the audio was not working and I had to read that. Because I think part of the power of that clip is to hear the tone in the doctor's voice as well. So if you are interested in hearing this clip, you can probably Google Michael Hickson. There's a story by NPR that also includes the audio that you couldn't hear today. But Michael Hickson ultimately died on June 11th at St. David's South Medical Center in Austin, Texas, after the hospital moved him from the ICU to hospice care. His wife stated he was denied potentially life-saving treatment due to his disability and doctors' biases, that because of his disability, he had a low quality of life. However, the hospital states they acted based on his dire diagnosis and that further care would have been pointless and cruel. So as this case demonstrates, the COVID-19 pandemic elicited concerns in the SCI community and among professionals as well about medical discrimination, medical rationing, and ultimately the impact on overall and mental health. I want to pause here for a second to define these terms. So medical rationing is the allocation of scarce resources, which in healthcare necessarily entails withholding potentially beneficial treatments from some individuals. And medical or healthcare discrimination involves discrimination in the provision of healthcare services. So I'm going to switch gears a little now and begin to describe our longitudinal study and then provide some data on medical discrimination and rationing that we found in our study. These data are primarily descriptive, but provide a snapshot of concerns about medical rationing and discrimination among the SCI community early on and during the first year of the pandemic. So for this study, we recruited participants internationally through distribution of recruitment materials to several SCI stakeholder groups, including the North American Spinal Cord Injury Consortium, the Paralyzed Veterans of America, and the European Spinal Cord Injury Federation. We also recruited participants through social media channels, including Twitter and Facebook. And participants included in the study had to have a diagnosis of spinal cord injury or disorder through self-report. They had to be 18 years or older, and they had to be able to comprehend English. And we realized this was a major limitation of an international survey, but due to the fact that this study was unfunded, we weren't able to get it translated into multiple languages. So on the right-hand side of the slide, you can see our enrollment in the study. So we had 340 people who visited the survey website. 111 of those people did not complete the consent form and 11 declined consent. We ended up enrolling 218 participants. However, we excluded 31 from the analyses due to several reasons, like incomplete information or missing data on all measures. And so at the baseline time point, we ended up analyzing 187 individuals. This shows the number of participants who responded to our survey at the various time points. So as I mentioned, this was a longitudinal study. We collected data at baseline, which was between May and August of 2020. Then we collected data at 3, 6, 9, and 12 months after that baseline time period. So at 3 months, we had 120 people respond to the survey. At 6 months, we had 119. At 9 months, our enrollment dropped a little down to, or not our enrollment, but the number who responded dropped down to 89. And then it bumped back a little at 12 months to 104. So I do want to say that I think these are pretty impressive numbers, given that we asked people to respond to questionnaires over the course of a year, and that this, again, was an unfunded study. So none of these participants were compensated for their time. So I really do want to thank the spinal cord injury community for participating in this study, especially being uncompensated. So as I mentioned, these are community dwelling adults with spinal cord injury, and these data were collected online using REDCap between May 2020 and August 31st of 2021. With regard to medical discrimination and rationing, we asked participants to respond to 3 questions. So the first one was, if you are hospitalized during the COVID-19 pandemic and need a ventilator, are you concerned that you will not get one due to your spinal cord injury? Yes or no? We asked, in the past 3 months, do you believe medical discrimination in the form of medical rationing is currently taking place where you live? Yes or no? And finally, if you are now or in the future diagnosed with COVID-19, how fearful are you that you will not receive appropriate medical care, for example, access to a ventilator, because of your disability status? And on this question, we asked participants to rate their concern on a slider scale from 0 to 100, from not at all fearful to very fearful. So this table here shows how our participants responded to these questions at the baseline time period. So if you are now or future diagnosed with COVID-19, how fearful are you that you will not receive appropriate medical care because of your disability status? People were moderately concerned. So this was the mean from 0 to 100, it was 43.8. If you're hospitalized during the COVID-19 pandemic and need a ventilator, are you concerned that you will not get one due to your spinal cord injury? And 30% of participants said yes, they were concerned that they wouldn't get one because they had a spinal cord injury. And in the past 3 months, do you believe medical discrimination in the form of medical rationing is currently taking place where you live? About half of our participants, 48%, said that they believed that medical discrimination in the form of medical rationing was currently taking place where they lived. This shows the data over time. So as you can see, this is the baseline data for that question. Do you believe medical discrimination in the form of medical rationing is currently taking place where you live? So as I mentioned on the slide, the previous slide, 48.1% of our participants said yes, they believed it was occurring. So yes is shaded in the light blue here at the top of the bars. At 3 months, that dropped to 23%. Stayed pretty stable at 6 and 9 months, around 28% each, and then dropped to 11.2% at 12 months. This graph here shows how participants responded to the question over time. How fearful are you that you would not receive appropriate COVID-19 care due to your disability status? And again, this was on that slider scale from 0 to 100. See, as you can see at baseline, people were moderately concerned. That dropped a little at 3 months. It bumped up again at 6 months. I'm assuming this was associated probably with a spike, and then dropped pretty significantly at 9 and 12 months. And when I say significantly, it wasn't statistically significant, just it dropped a fair amount. So consistent with reports from the healthcare industry, at the beginning of the pandemic, over half of participants perceived that discrimination through medical rationing was occurring. And this finding is congruent with concerns from disability rights advocates and many bioethicists that disabled people were and are being deprioritized for care, and that unfair approaches to rationing disproportionately affect patients with COVID-19 who are also disabled. So there's definitely a need for advocacy, and the onus must not solely be on patients and their support system to advocate for themselves, particularly as we saw during the pandemic with social isolation and social distancing in place in acute care settings, which often limited access to visitors. And healthcare professionals have a duty to advocate within their community and healthcare systems for transparent and fair crisis care guidelines and triage protocols that do not unfairly discriminate against people with disabilities. Healthcare professionals can also advocate for bulk provision of medical supplies to disabled patients, promote full accessibility of testing and services related to COVID-19, ensure that communications about COVID-19 are fully accessible to the disability community, and coordinate support for those with the most complex needs, and also educate other healthcare professionals about the heightened risk that COVID-19 poses to the disability community. So next, I'm going to discuss a little bit about the supply chain issues, including access to medical supplies and also access to personal care assistance. So participants were asked 3 questions related to access to medical supplies and PCAs. So participants who indicated that they required a PCA or nurse were asked to rate the impact of the pandemic on the care they received in their home on a scale from 1, no impact, to 4, major impact. And all participants were asked to rate the impact of the pandemic on their access to medical supplies on a scale from 1, no impact, to 4, major impact, and how concerned they were about access to medical supplies on a scale from 0, not concerned at all, to 100, very concerned. At the 3-month time point, we also asked participants to rate the impact of the pandemic on access to specific medical supplies. And this was in collaboration with the advocacy committee of ASCIP, who contacted me and asked me to add this to our survey. And so these are the specific supplies that the advocacy committee suggested that I add to the survey. So here are the results. Again, this was at the baseline time point. So how concerned are you about access to medical supplies? On that slider scale from 0 to 100, the mean was about 39.5. So I would say about moderate concern. So how has the pandemic impacted the care you receive in your home? 60% of our participants said it had some impact, from minor to moderate, on the impact they receive in their home. So you can see the majority there said it was a minor impact, 36%. 18% said it was a moderate impact, and about 6% said a major impact. And then this last row here, how has the pandemic impacted access on medical supplies? Again, about 60% of our sample said that the pandemic had impacted their access to medical supplies, either minor, moderate, or major impact. And this here shows the categories of supplies that were impacted at each survey time point among those who reported an impact. So the blue bars indicate the 3-month time point, the orange is the 6-month time point, the gray is 9 months, and the yellow is 12 months. So you can see here that the most commonly reported supplies that were impacted were gloves, then bowel care supplies, then wheelchair parts, and then other. And that other category was an open text field, and the most common responses were masks and urostomy supplies. So this graph here shows the proportion of the cohort that was impacted at each survey time point. So about 45% of the cohort was their access to medical supplies were impacted at 3 months, and that dropped to around 40% at 6 months, around 35% at 9 months, and stayed around 35% at 12 months. And the median number of supply categories impacted was 2 for all time points. So individuals with spinal cord injuries have reported more difficulty accessing medical supplies due to the pandemic than the general US population. Although not a direct comparison to medical supplies in general, a tracking poll by the Kaiser Family Foundation found that 4% of the general population had been unable to get prescription medication, while 50% of participants in our sample reported that the pandemic had negatively impacted their ability to access medical supplies. Compared to the general population, the SCI population is more likely to require medical supplies. Therefore, shortages of these medical supplies, including PPE, disproportionately affect the SCI population and the broader disability community. Next, I'll be talking about some of our results on general health, social isolation, and mental health. So participants were asked 2 questions related to their current health. Compared to before the COVID-19 pandemic, how would you rate your current health? From much worse to much better? And how has the COVID-19 pandemic impacted your overall health on the same scale? And then they were asked 1 question related to their mental health. How has the COVID-19 pandemic impacted your mental health? And they rated that on the same scale from 1 to 4. So this slide here shows the results in our sample compared to the same questions asked in the Kaiser Family Foundation survey, which was given to the general US population at around the same time point that our survey was given. So you can see here in our sample, the SCI sample, they rated 63.4% rated their current health as excellent, very good, or good, compared to 83% of the general US population. Impact of the pandemic on their overall health. So 68% of our participants in our sample said that the pandemic was impacting their overall health compared to 45% in the general population. 71% of participants in our sample said that the pandemic was negatively impacting their mental health compared to 45% in the general population. And then 16% of participants in our sample said that the pandemic had led to lost income or unemployment compared to 39% in the general US population. We also asked some questions about social isolation. So how bothered people were by social isolation. They rated that on that scale from 0 to 100. So you can see people were fairly moderately bothered by social isolation. And on that same 0 to 100 scale, we asked, how concerned are you about future social isolation? And the mean there was 61. So compared to the general population, initial findings from our online survey show that the pandemic has a greater negative impact on the mental health of individuals with SCI. The Kaiser Family Foundation poll showed that by early April 2020, 45% of respondents reported the pandemic had affected their mental health, with 19% reporting it had a major impact. In our sample, 71% of participants reported the pandemic had impacted their mental health, with 46% reporting it had a major or moderate impact. So next I'm gonna talk about 2 studies that were published from these data. Well, one study, this first one was published, the other one is under review, looking at these constructs in more detail. So the first study is resilience and mental health in individuals with spinal cord injury during the COVID-19 pandemic. And the objective of this study was to understand how resilience, access to PCAs and medical supplies, and concerns about medical rationing, finances, and social isolation are related to overall and mental health in individuals with spinal cord injury in the context of the pandemic. Again, these were community dwelling adults with spinal cord injury. This was at the baseline time point. So we had 187 participants. And this study reports cross-sectional findings from the larger longitudinal data set. So our outcomes were many of the things I had just gone over. So the questions about overall health, the questions about impact on mental health. We also measured depression symptoms using the PHQ-8. We measured anxiety symptoms using the GAD-7, and we measured quality of life using the spinal cord injury quality of life basic data set, which assesses 3 aspects of quality of life: overall well-being, satisfaction with physical health, and satisfaction with psychological health. We had several predictors in this study. So resilience was a predictor, which we measured with the SciQual resilience short form. We included our items about medical rationing and discrimination as predictors. We also included financial concerns, impact on care in the home, impact on access to medical supplies, and the questions about social isolation. So the outcomes of overall and mental health were modeled using ordinal logistic regression. Depression, anxiety, and quality of life outcomes were modeled using linear regression. And all candidate predictors were considered for each outcome model. Due to the large number of candidate predictors, modeling was done in stages, with the candidate predictors grouped a priori as follows: demographic information, injury-related characteristics, medical discrimination and rationing, and resilience. So in the ordinal logistic regression model of overall health, completeness of injury, fear of not receiving medical care due to disability status, major impact on access to medical supplies, and being bothered by social isolation all significantly predicted a negative impact of the pandemic on overall health. Individuals with complete injuries had a 53% lower likelihood of reporting that the pandemic had an impact on their overall health compared to those with incomplete injuries. Participants who were more fearful of not receiving medical care due to their disability status were slightly more likely to report their overall health being negatively impacted by the pandemic. And participants who reported a major impact on their access to medical supplies were over 10 times more likely to report that the pandemic had impacted their overall health compared to participants who reported no impact on access to medical supplies. And finally, participants who reported being bothered by social isolation were slightly more likely to report that the pandemic had an impact on their overall health than those who were not bothered by social isolation. Time since injury and minor or moderate impact on access to medical supplies did not significantly predict impact of the pandemic on overall health. In a second ordinal logistic regression, we identified several factors associated with perceived impact of the pandemic on mental health. So for each additional year of age, the odds of reporting a greater impact of the pandemic on overall health decreased by 2%. And participants who expressed fear of not receiving medical care due to their disability status, and those who were more bothered by social isolation, were slightly more likely to report a greater impact of the pandemic on their mental health. And participants with higher resilience scores were 10% less likely to report that the pandemic had negatively impacted their overall health. To examine predictors of anxiety and depression symptoms, we ran multivariable linear regression models. In this model, concerns about personal finances and fear of not receiving medical care due to one's disability status were associated with increased anxiety, and greater resilience, in contrast, was associated with decreased anxiety, which is what one would expect. And in this multivariable linear regression model with depression as the outcome, complete spinal cord injury and higher levels of resilience were associated with fewer depressive symptoms. Conversely, a belief that medical rationing was occurring, concern about personal finances, and being more bothered by social isolation were associated with increased depressive symptoms. In this model, participants who expressed concern about personal finances were more likely to report decreased overall well-being. And conversely, those individuals who reported higher resilience Specifically, a score greater than or equal to 18 on the SciQual Resilience Scale reported greater overall well-being. And participants who reported a fear of not receiving medical care due to their disability status were less satisfied with their physical health. As with overall well-being, those individuals with a SciQual Resilience score greater than or equal to 18 reported greater satisfaction with their physical health. And finally, participants who reported concern about future social isolation were less satisfied with their psychological health. As with overall well-being and physical health, those individuals with a SciQual Resilience score greater than or equal to 18 reported greater satisfaction with their psychological health. So that was a lot to digest. So in conclusion, our results indicate that concerns about medical rationing are associated with negative health outcomes in the spinal cord injury community during the pandemic. Specifically, individuals with spinal cord injury who had concerns about accessing medical supplies due to their disability status reported worsened health outcomes, including poorer overall health, poorer mental health, increased anxiety symptoms, and poorer physical health. Similarly, the belief that disability-based discrimination and rationing of medical supplies was occurring was also associated with more depressive symptoms. These concerns in the SCI community regarding medical rationing are grounded in the realities of resource scarcity and historical precedent, but several options exist to possibly allay these fears and improve the overall mental health of those with SCI during our current crisis. The SCI community should be made aware of their legal right not to be excluded from care based on the basis of their disability. An interdisciplinary healthcare team should be encouraged to involve rehab psychologists who can advocate on behalf of individuals with SCI to prevent unfair discrimination as it relates to access to medical supplies and healthcare. And finally, bulk provisions of medical supplies should be made available to individuals with SCI to not only reduce the need to access public spaces such as pharmacies or medical supply stores that would increase the risk of contracting the virus, but also to reduce the likelihood of any medical supply shortages for these individuals. So this study that I'll be talking about next is the one that is under review, and it is on changes in essential care among individuals with spinal cord injury during the pandemic. And the purpose of this study was to determine whether changes in essential care during the pandemic impacted satisfaction with activities, participation, and relationships among individuals with spinal cord injury. Again, this was community dwelling adults, 123 participants with spinal cord injury at the 6-month time point. Again, this was a cross-sectional study from the larger longitudinal study. Our outcomes were overall health, mental health, depression symptoms, anxiety symptoms, and quality of life. We had additional outcomes in terms of activities and participation. And for this, we used the International Spinal Cord Injury basic data set for activities and participation. And we looked at satisfaction with the ability to complete activities of daily living, including mobility, dressing, feeding, and toileting, as well as satisfaction with household activities and recreational activities, satisfaction with relationships among family and friends, and satisfaction with the status of one's relationship. Our predictors were age, gender, time since injury, completeness of injury, injury level, access to mental health, access to medications, access to medical supplies, and access to PCAs. For this study, we used multiple linear regression to assess the effect of the predictor variables on the outcome variables while controlling for demographic and injury characteristics. Each outcome variable was modeled with the primary predictor candidate variables and demographic and injury variables. And we used manual stepwise elimination to determine the final model for each outcome. So here are the results in terms of ADLs. So with regard to mobility, increased impact on access to mental health support was associated with decreased satisfaction in mobility. Increased impact on access to PCA or home or services in the home was associated with decreased satisfaction in feeding. And injury classification, para or tetra, and increased impact on ability to maintain equipment were associated with decreased satisfaction in toileting. With respect to participation, Increased impact on access to medical supplies was associated with decreased satisfaction with participation in household activities. Increased impact on access to mental health support was associated with decreased satisfaction with participation in recreational activities. And again, an increased impact on access to mental health support was associated with decreased satisfaction with family relationships. And finally, increased impact on access to mental health and increased impact on access to medical supplies were both associated with decreased satisfaction with friend relationships. Again, that was a lot to digest. So in summary, impact on access to mental health and impact on access to supplies were the most common factors affecting satisfaction with activities, participation, and relationships. So in conclusion, future supply chain disruptions from pandemics or natural disasters could have wide-reaching effects for individuals with spinal cord injury. Further research and advocacy is needed to improve mental health care planning and supply chain access during subsequent natural disasters or pandemics. And I do want to take a moment to highlight the publications that have come out of this data set so far. The resilience one is the one I reported on today. We also have a qualitative study that I collaborated with some collaborators in the UK on the impact of the pandemic, primarily on mental health. And there was one published in Rehabilitation Psychology on concerns about medical rationing and social isolation. And that was primarily the first data that I discussed today. And then, as I mentioned, there's a few publications that are under review. The second study I talked about today, the changes in essential care. And then we have another qualitative study comparing the impact of the pandemic on individuals in the US and comparing that to the findings we found in the UK. And at this point, Leslie, I think we will turn it over to our discussants.
Okay, thank you, Kim, for an excellent presentation. As people are typing questions into the chat box, I'd like to introduce our discussants, Clark and Molly. Molly and Clark met in 2006 at Southwest Minnesota State University in Marshall, Minnesota. Clark was 5 years into his spinal cord injury when Molly met him working as his PCA in college. They currently reside in Hollingford, Minnesota with their two Aussie Doodle dogs, Bailey and Jax. Clark is a mechanical engineer, and along with still providing care to Clark, Molly is an information security analyst. In their spare time, they enjoy fishing and walks on the Lake Wobegon Trail. Clark and Molly, thank you for joining us today.
Awesome. Thank you for having us as guests to this presentation. Just a little summary of our story. At the beginning of the COVID-19 pandemic, we discussed stopping having the PCAs come in and helping Clark just to limit our exposure. I was already working from home and Clark began working from home, and we were just, trying to play it safe. In the end, we decided to keep the PCAs coming. Just providing care by myself is a lot. And also those PCAs depend on that income. And so in the already world of short, we can't find PCAs. If we ask them to not come, they're going to find other jobs and we'll never have anybody. In April of 2021, COVID hit our house. We stopped then and they take care of other people. And so then I was doing all of the care. I ended up getting super sick. Clark's mom came to help. And then it progressed for myself. I ended up in the ICU for like 7 days, and Clark, the COVID, it didn't hit him as hard. It was about a 24-hour thing. And obviously with spinal cord injury, but it's concerned him, respiratory and things, and it didn't get him as hard. Another thing during the pandemic that was we couldn't get them from our normal suppliers, so I went on. I started calling all these people like catheters, and I finally found a box that it made us through until the next place could catch up. I'll pass it over to Clark. He's gonna touch on some other things.
So I had a little bit of
don't know what happened.
Oh, you're back.
Are we okay?
We can't, we don't have video, but we can hear you.
Okay. So I had a little bit of survivor's remorse when Molly went into the hospital. I thought it should have been me at that point, but I just had to keep going on like normal. I feel like once she got out of the hospital, things took a little bit of time to get back to normal. But one of the things that has impacted me, impacted us long term now, is we're starting to lose our PCAs because of the pay, and as a result of the pandemic, with inflation and things going the economy away, we're now finding that they're finding more work at higher paying jobs. One of the ways that I think people with spinal cord injuries is treat everybody as humans, and not just because you have a disability that you're not you're like with the guy at the beginning of the discussing here, that everybody's a human no matter what. Everybody has some type of disability. It's not because of walking or whatever. And I think in the end, if people treat everybody as humans, the doctors treat everybody as humans, but even with SCI, I think it would go a long way in helping this community.
That's it from us.
Well, I'm monitoring the Q&A in the chat, and I don't see any questions. So I'd like to invite anybody from the audience, if you have any questions or comments, to please share them now.
So I have one question. We kind of talked about it when we were doing this, and like how healthcare professionals, Clark kind of talked about it, like treating everybody as a human. But Dr. Kimberley, do you have any thoughts on that, like from your aspect on like what healthcare professionals can do for the spinal cord injury community?
Yeah, so I think, as I mentioned early in the presentation, which I think some of these things did come into play a little later on in the pandemic, but advocating for bulk provision of supplies, I think was, a big thing. So instead of insurance only allowing for a 30-day prescription, allowing for 90-day prescriptions to limit exposure. And I think that's our duty as healthcare professionals to be advocating for those things. And I think really involving a multidisciplinary team to advocate for individuals, especially individuals with disabilities, like in the case of Michael Hickson. I think that case went to an ethics board, so I'm not sure what else could have been done there. But I think the more you are including PM&R and rehab psychology and people who are familiar with working with people with disabilities and helping to advocate for them, I think that's really important.
So we did have one type of a little bit of discrimination with having COVID, trying to get the
Antibody transfusion.
the antibody transfusion when we got it, and because I wasn't overweight enough or I wasn't of an age, even in March of or April of 2021, I was still not able to get that. And so trying to be preventative, because I didn't know how hard it was going to impact me. I knew I had a positive COVID test, but that was one of the parts that was really tough.
Right. Leslie, are you seeing any other questions or comments?
I'm not. I'm looking in the Q&A and let me just check the chat. No.
Okay.
And I guess if not, I would like to thank our speakers and discussants for their participation. Actually, we've opened the chat and moderated that. So I guess I'd like to thank you all for attending today's grand rounds. We apologize if not all questions were answered. Please feel free to reach out to the presenter directly if you'd like to follow up regarding your question. The recording for the webinar will be posted soon on the SCIMS website. As a reminder, please see the chat for information on how to obtain CME for attending today's webinar. At the end of the webinar, a brief 3-question survey will pop up. We would appreciate your feedback. We also hope you can join us for our next grand rounds on July 7th at noon Central Time, where Dr. Daniel Rowe will present sexuality and sexual function in SCI. Thank you and have a great rest of your day.